All right, let's go. Number 10. Pervitin. The Temmler pharmaceutical factory in Berlin was, by every external measure, an ordinary commercial operation. Production lines, shift workers, quality control inspectors moving between stations with clipboards, delivery trucks leaving the loading dock on a schedule that had not changed since the factory opened. In 1938, Temmler had developed a new product, a small white tablet sold over the counter at German pharmacies alongside aspirin and vitamins. The advertising was cheerful. The packaging was clean and modern. Housewives bought it for energy. Students bought it before examinations. Truck drivers bought it for long hauls through the night. A chocolate manufacturer even produced a version called Hildebrand chocolates, marketed to the general public as a mild stimulant for busy modern lives. The product had a brand name, Pervitin. The active ingredient did not appear prominently in the advertising. In the spring of 1940, the Wehrmacht placed an order that the factory's existing production capacity could not immediately fill. The order was for 35 million tablets. Temmler expanded its production lines. The tablets went into the supply chain of an army preparing the fastest military conquest in European history. The active ingredient was methamphetamine. Otto Ranke had understood what he was ordering before he ordered it. Ranke was the director of the Institute for General and Defense Physiology at the Academy of Military Medicine in Berlin, and in the winter of 1939 he had run a clinical trial on 88 university students subjected to sustained physical and cognitive stress. The trial tested Pervitin's capacity to suppress fatigue under operational conditions. The results were better than any projection. The students continued performing at baseline levels, past the point at which unmedicated humans become physiologically incapable of sustained effort. Ranke understood the Blitzkrieg doctrine's specific requirement. Armored warfare in 1940 demanded soldiers who could remain effective for 72 hours without sleep. The tanks did not stop moving because the crews needed rest. The crews needed to not need rest. Pervitin solved that problem with a precision that no other available compound could match. The order went in. Within 6 weeks, Germany had conquered France. What methamphetamine does to the central nervous system is not complicated. It floods the synaptic gap with dopamine at a volume the brain does not produce under any natural circumstance. The sleep drive, which is a chemical accumulation of adenosine in the brain's basal forebrain, is not suppressed. It is simply overridden by a signal so loud it cannot be heard beneath the noise. The adrenal system fires as though the body is under immediate physical threat, because neurochemically it is. The heart rate climbs, the peripheral blood vessels constrict, the muscles receive priority blood flow. A soldier on Pervitin was not rested. He was spending biological capital at a rate the body charges compound interest on. The performance was real. The debt was also real. Every hour of artificial wakefulness was an hour the body would eventually collect. The soldiers wrote home during the Blitzkrieg campaign. Some of the letters survived. They described a feeling of invincibility that the men themselves found difficult to account for. One soldier wrote that he had been awake for 3 days and felt as though he had just risen from 8 hours of sleep. Another described the sensation of moving through the campaign as though time had been compressed, events happening faster than memory could record them. The aggression was noted in field reports. Men who had been described by their officers as cautious and methodical became decisive to the point of recklessness. Some became violent toward their own units in the periods between doses. The crash, when the supply ran out, was documented in field medical logs as a sudden and total collapse of function. Men who had been operating at peak effectiveness for 72 hours became unable to stand within hours of the last tablet. Cardiac events were recorded, psychosis was recorded. The field logs described what they saw. They did not always know what they were describing. By 1941, the Wehrmacht's medical division knew. The internal reports that reached Reich medical authorities by the summer of that year described an addiction crisis emerging from the front lines with a clarity that left no room for alternative interpretation. Soldiers were requesting Pervitin through unauthorized channels. Men who had returned from the French campaign were presenting at military physicians with dependency profiles that the physicians recognized and that had no approved treatment pathway. The reports were classified at the highest level available to the medical division. Pervitin's status was quietly changed from open ration to controlled substance. The public was told nothing. The soldiers who came home dependent were absorbed into the general category of men damaged by war, which was already so large that the specific pharmacological component was invisible inside it. Norman Ohler, in his 2015 study Blitzkrieg, documented using previously classified Wehrmacht medical records that over 35 million Pervitin tablets were distributed to German forces during the French campaign alone, and that internal medical reports describing addiction and psychosis were classified at the highest level within the Reich medical establishment by the summer of 1941, with no corresponding treatment program established for affected personnel. Every military with a research budget and an aviation program has, since 1945, run some version of the same calculation that Otto Ranke ran in 1939. The compound changes. The question does not. The RAF issued Benzedrine to bomber command crews on long-range missions. The United States Air Force issued dextroamphetamine to combat pilots in Korea and Vietnam, and continues to issue modafinil and dextroamphetamine to combat pilots today. The Go pill is the institutional descendant of the Pervitin tablet. The pharmacology is different. The decision architecture is identical. A commander determines that a mission requires sustained performance beyond the biological limit. A physician determines which compound produces that performance at acceptable risk. The compound is issued. The question of what happens to the men when the compound stops working is addressed, if it is addressed at all, by a system designed primarily to return them to operational status rather than to restore what the compound cost them. The Go pill has never gone away. It has only changed its name, its chemical formula, and the flag on the uniform of the person swallowing it. Number 9. Benzedrine. In the spring of 1942, a Royal Air Force medical officer named Henry Winfield was reviewing the operational performance records of bomber command crews flying long-range night missions over Germany, when he found something the operational data alone could not explain. Crew error rates were inconsistent across squadrons in ways that fatigue alone did not account for. Navigation failures, instrument misreadings, and decision failures at critical moments were distributed unevenly across units flying identical mission profiles in identical conditions. Winfield pulled the crew debrief transcripts. What he found buried inside them was a pattern of Benzedrine use that had no standardization, no protocol, and no oversight. Some crews were dosing twice what others had taken. Some had taken nothing. Some had taken tablets obtained informally from unit medics at timings that bore no relationship to the mission profile. The RAF had been issuing Benzedrine to Bomber Command for months. No one had issued instructions on how to use it. The performance drug had been distributed without a performance protocol. What it was producing in the gap between distribution and protocol was an operational problem that looked, in the data, like human error. The British and American amphetamine programs did not emerge from a vacuum. German Pervitin use had been noted by Allied intelligence by 1940, and the pharmacological logic of stimulant enhancement for sustained military operations was not a German invention. Smith, Kline, and French had been manufacturing Benzedrine in the United States since 1934. The compound was available, understood, and already part of the commercial pharmacopoeia when the war began. What the war did was convert a civilian medical product into a military supply item at a scale that the civilian market had never approached. The RAF formally adopted Benzedrine for Bomber Command in 1942. The United States Army Air Forces adopted it for long-range Pacific aviation. Both programs arrived at the same pharmacological solution through independent institutional decisions made within months of each other, which was not a coincidence. It was the logic of the problem. The mission required sustained performance. The compound produced sustained performance. The rest was procurement. The official communications around Benzedrine in both Allied militaries used a specific language: medical support, fatigue management, operational medicine. The word stimulant appeared in internal documents. It did not appear in the public communications. The poster campaigns and official publications that shaped the Allied population's image of their fighting men did not include the detail that those men were being issued amphetamine tablets before long-range bombing missions. The image of the steady, clear-eyed Allied airman and the chemical reality of the Benzedrine tablet in his breast pocket occupied different registers of the official narrative simultaneously. One was public, one was in the supply manifest. Who received Benzedrine and at what dosages was not a random distribution. Bomber command crews received a standardized allocation tied to mission length. American Pacific aviation units received allocations that varied by theater command and mission profile. Infantry units in both militaries had access through unit medics that was informal, untracked, and entirely at the discretion of the medical officer, which meant the difference between a frontline infantryman who received pharmaceutical fatigue support and one who did not was the personality and supply connections of the man running his unit's medical kit. The pilot in the cockpit had a protocol. The soldier in the foxhole had whatever the medic happened to have. The pharmacological architecture of the Allied military followed the same class lines as everything else. The veterans who came home from both theaters came home with Benzedrine habits that the Veterans Administration in both countries did not recognize as service-connected, because the distribution had been informal enough in many cases that no record existed connecting the individual to the supply. The pharmaceutical industry, which had spent the war years producing amphetamine at military scale, found itself in the post-war period with manufacturing infrastructure, distribution networks, and a population already familiar with the compound's effects. The prescription amphetamine market of the 1950s, the diet pills and the mood elevators and the stay alert tablets sold legally across the United States and Britain through the decade, was seeded in part by a military distribution program that had introduced millions of people to the compound under conditions that the post-war civilian market was happy to continue servicing. Nicholas Rasmussen, in his 2008 study on speed, documented using declassified military supply records that the United States military alone distributed approximately 180 million Benzedrine tablets during the war, a figure equivalent to roughly one tablet for every adult in the United States at the time, and a figure that was not included in any official post-war account of the American pharmaceutical program. But here is where the conventional reading collapses into something stranger. 180 million tablets is not selective use. It is mass medication of a military force with a dependency-forming stimulant, administered without informed consent, without addiction monitoring, and without any institutional plan for what happened to the men who came home with the compound still governing their baseline sense of normal. Germany classified its addiction crisis in 1941. The Allies produced one of comparable scale and simply did not count it, because counting it would have required acknowledging that the distribution had happened at a scale the official narrative had not disclosed. Both sides medicated their men with the same class of compound, for the same reasons, with the same consequences, and both sides wrote the same kind of history afterward, one that mentioned the pills and left out what happened when the pills ran out. Number 8. Cocaine in the Wehrmacht medical kit. 20%. That is the concentration of cocaine hydrochloride solution, documented in standard Wehrmacht forward aid station supply manifests, recovered by Allied forces in 1945. 20%. The maximum concentration permitted for any clinical application of cocaine in any modern medical system anywhere on Earth is 4%, used for specialist ear, nose, and throat procedures, administered by a licensed physician in a controlled clinical environment with cardiac monitoring. The solution being applied to open wounds on the Eastern Front by field surgeons working in requisitioned farmhouses with no sterile equipment, no specialist oversight, and no cardiac monitoring was 5 times that concentration. It was not an improvisation, it was the specification. The number was on the supply manifest before the first soldier was wounded. The standard Wehrmacht medical kit was a compact leather case approximately the size of a modern laptop bag, designed to be carried by a single medical orderly and to contain everything required for initial wound management in a forward position. What it contained, beside the field dressings and the morphine syrettes and the sulfonamide powder, was a set of glass vials containing cocaine hydrochloride solution in a concentration that would require controlled substance authorization, specialist training, and clinical monitoring in any contemporary medical setting. The vials were labeled in military pharmaceutical German. The instructions described an application protocol, topical application to wound margins and wound cavities before surgical intervention, that was entirely standard within the Wehrmacht medical system and entirely outside the parameters of any contemporary medical framework. The kit was issued. The vials were in it. The orderly who opened the kit in a forward position had been trained to use what was inside. The forward aid station on the Eastern Front was whatever structure happened to be available: a farmhouse, a barn, a cellar. In winter, the air temperature inside was often not meaningfully different from the air temperature outside, which meant the surgeon's hands were cold and the patient's peripheral circulation was compromised, and the cocaine solution's absorption profile was altered from what any controlled environment would have produced. The smell of the aid station was blood and unwashed bodies, and the chemical sharpness of disinfectant solution, and, underneath those, the particular sweetness of cocaine solution applied to open tissue, which medical personnel who worked in those stations described in post-war accounts as unmistakable, once encountered, and impossible to forget. What cocaine anesthesia produced in the patient was a silence that followed the application by a specific interval. The wound was present. The pain was not. The surgeon worked in that silence. The failure cases were in the field logs. Soldiers who had lost significant blood volume before reaching the aid station presented with cardiovascular profiles that cocaine's vasoconstrictive properties could not safely accommodate. The compound that narrowed blood vessels in a normovolemic patient produced cardiac events in a patient already at the edge of circulatory compromise. The logs recorded the outcomes with the clinical detachment of men who had seen too many outcomes to record them any other way. Beyond acute toxicity, the soldiers treated repeatedly across a campaign, the ones who cycled through the aid station with recurrent wounds or wound infections requiring multiple procedures, developed dependency profiles that the field medical system had no framework to address. They were treated and returned to their units. What they returned to their units with, in addition to whatever wounds had been managed, was a physiological relationship with cocaine that the supply chain had created, and the supply chain would not continue to service once the wound was closed. The Reich's cocaine supply came from South American coca leaf imports processed through German pharmaceutical facilities, primarily Merck and Boehringer, who had been producing pharmaceutical cocaine for the European medical market since the 19th century. The Allied naval blockade that tightened progressively from 1941 onward choked that supply chain with an efficiency that the Wehrmacht Medical Division's supply forecasts had not adequately anticipated. The substitutes, Procaine and Novocaine, which German pharmaceutical chemists had developed as synthetic alternatives beginning in the early 20th century, were available and could be produced domestically without reliance on imported raw materials. They did not perform equivalently under field conditions. Procaine at comparable concentrations produced shorter duration anesthesia with a higher incidence of allergic reaction. Novocaine required a longer onset time that field surgery schedules could not always accommodate. The degradation of anesthetic capability across the later war years, as cocaine availability declined and synthetic substitutes proved inadequate, is documented in the field medical logs as a progressive deterioration in surgical outcomes that the surgeons themselves identified and recorded without being able to address. Wolfgang Wolk, in research published in the journal Medizin Historisches Journal in 2003, documented that Wehrmacht medical supply records from the Eastern Front describe cocaine hydrochloride concentrations in field anesthetic application that exceeded any contemporaneous Western Allied protocol by a factor of 3 to 5, and that the field surgical mortality data associated with those concentrations was classified within the Reich medical establishment and not released until decades after the war. But here is where the nightmare begins. The cocaine was not a pragmatic improvisation developed under duress by surgeons doing their best. It was the specification. The concentration that would today require specialist oversight and controlled clinical conditions was the number written on the supply manifest before the campaign began. The decision to issue cocaine at 20% concentration to forward aid stations was made by named officials in the Reich Medical Administration using data from the field trials that had preceded the campaign. The wounded soldier in the barn did not choose his anesthetic. The field surgeon did not choose his supply list. Both were inside a system that had made its pharmacological calculations before either of them arrived at the farmhouse. The arithmetic was complete before the wound was made. The cocaine in the medical kit was not a scandal. It was a specification. Someone wrote the number on the supply manifest. Someone approved the number. The wounded man in the barn had no part in the decision. He simply received it. Number 7. Sontochin. The Bayer Pharmaceutical Research Facility at Elberfeld in 1940 occupied a campus of stone and glass laboratory buildings on the Wupper River in western Germany, the kind of institutional architecture that signals serious science conducted by serious people with serious resources. Researchers in white coats moved between buildings carrying notebooks and sample cases. Chemical apparatus occupied the benches in orderly configurations. The facility had been producing pharmaceutical compounds for the global market since the 19th century. It had given the world aspirin. It had given the world heroin, briefly, before that compound's profile became inconvenient. In 1940, it had a problem. The quinine supply had been cut. The Allied naval blockade had begun its progressive strangulation of German import chains, and quinine, which came from the bark of the cinchona tree grown in the Dutch East Indies, was among the first casualties. The laboratory was given a mandate: find a replacement. What it found, and how the replacement was tested, does not appear in any standard account of pharmaceutical history. The test subjects are not named in the published research. They are not named in the published research because naming them would have required explaining what they were doing in a pharmaceutical laboratory in the first place. Quinine had been the only reliable anti-malarial compound available to any military force operating in tropical theaters since the 19th century. When Japan seized the Dutch East Indies in early 1942, it did not merely cut the German supply. It cut the Allied supplies simultaneously. Both sides lost access to the world's primary quinine source within weeks of each other, which meant that both sides were suddenly running tropical campaigns, in North Africa and in the Pacific, with a malaria problem and no established pharmaceutical solution. The scale of the problem was not abstract. In the North African campaign, malaria casualties in certain British and German units exceeded combat casualties during specific operational periods. On Guadalcanal in 1942, malaria incapacitated American forces at rates that at certain points threatened to determine the campaign's outcome, independently of Japanese military action. The side that solved the anti-malarial problem first had a genuine operational advantage. Both sides understood this. Both sides had their chemists working on it. The Bayer solution was Sontochin, a synthetic compound from the chloroquine family that the laboratory had been developing since the 1930s. By 1942, it was ready for efficacy and toxicity testing. The testing was conducted at the concentration camps at Dachau and Natzweiler under the supervision of SS physicians who were connected to the Ahnenerbe Research Division. The prisoners selected for the trials were deliberately infected with malaria through mosquito exposure or blood injection, then administered Sontochin at varying doses and schedules. The trial records documented outcomes in the language of standard pharmaceutical research: efficacy rates, dosage tolerances, side effect profiles. The prisoners who died during the trials appeared in the records as data points. Their names were not in the records. Their prisoner numbers were. The distinction between a name and a number was the administrative mechanism by which the trial could be conducted and recorded and filed and eventually cited without the filing and the citation requiring anyone to engage with who the data points had been before they became data points. The geography of malaria as a military problem in the Second World War is inseparable from the geography of the campaigns themselves. North Africa, the Mediterranean islands, the Pacific atolls, Burma, New Guinea. These were not random selections from the map of human conflict. They were the locations where the strategic objectives of the war coincided with the biological range of the Anopheles mosquito. The disease was not a side effect of fighting in those locations. It was a structural condition of fighting in those locations, as predictable as the terrain and as difficult to engineer around. The military that could suppress malaria in its force had a sustainable operational presence. The military that could not was losing soldiers to a parasite at a rate that no tactical brilliance could compensate for indefinitely. The trial records from Dachau and Natzweiler did not all survive. The SS medical administration at both facilities destroyed documentation before Allied forces arrived, with the thoroughness that characterized the Reich's final weeks of record management. What survived, because the destruction was incomplete, and in some cases because individual prisoners had memorized or hidden fragments of what was done to them, was enough to establish the outlines of the program. What Allied medical teams did with those outlines is documented in internal communications that were classified for decades. The decision was made by named officials in the Allied medical intelligence apparatus to treat the surviving data as pharmaceutical intelligence rather than exclusively as evidence of a crime. Both categories were available. The officials chose the proportion between them. Paul Weindling, in his 2004 study Nazi Medicine and the Nuremberg Trials, documented that data from concentration camp anti-malarial trials appeared in at least 3 post-war pharmaceutical publications without disclosure of experimental conditions, and that Allied medical authorities made documented decisions about the use of that data that prioritized pharmacological utility over evidentiary integrity. But here is where the standard explanation falls apart. The Nuremberg doctors' trial prosecuted physicians who had conducted human experiments without consent. It established, in the Nuremberg Code, that such experiments constituted crimes against humanity. It was running simultaneously with the institutional decisions to incorporate the data those experiments had produced into post-war pharmaceutical literature without disclosure. The prosecution and the incorporation were not in conflict within the institutions managing both. They were in different compartments. One compartment was open to the public, the other was classified. The data point in the published pharmaceutical study and the prisoner number in the Dachau trial record referred to the same event. Only one of them required attribution. The research that killed them did not die with them. It was filed, cited, and built upon. The compound that came after it does not carry their names. It carries their data. The distinction matters less than it should. Number 6. Ravensbrück. In the spring of 1947, a Polish physician named Zofia Monczka sat in a witness chair at the Nuremberg doctors' trial and described what had been done to her legs. She spoke in precise clinical language, because that was the language the tribunal required, and because it was the language in which what had been done to her had been designed and authorized and recorded. She described the incision, the deliberate introduction of bacteria into the wound, the suturing of the wound closed with the infection inside it, to replicate the conditions of a battlefield wound contaminated by soil and fragment material. The fever that followed, the specific quality of what the wound produced over the following days, which she described not as pain in the ordinary sense but as a process, something her body was doing against her will, with a specificity and persistence and direction that ordinary pain did not possess. The men listening to her included some who had designed protocols indistinguishable from what she was describing. Some of those men were in the dock. Some of them were in the gallery. The difference between the dock and the gallery was not the nature of their participation, it was the institutional connections they had maintained into the post-war period, and the utility of what they knew to the institutions now managing the question of accountability. The women selected for the Ravensbrück wound infection experimental program were chosen from the prisoner population by SS physicians, who reviewed physical condition, age, and what the selection documentation described as suitability for surgical procedure. They were Polish political prisoners in the majority, women who had been arrested for resistance activity and who had already survived the conditions of Ravensbrück for months or years before the selection. The ward where the experiments were conducted smelled of infected tissue and carbolic disinfectant, and the particular sweetness of fever sweat from bodies running temperatures that the infections the SS physicians had introduced were sustaining deliberately. The women called each other by their first names in the ward. They called the physicians by words that do not appear in the SS medical records. What happened to the women whose infections did not respond to the sulfonamide treatment being tested was recorded in the trial logs as outcome data. What it looked like from inside the ward was recorded in the testimony of the women who survived it, which is a different document entirely. The sulfonamide experimental protocol was not improvised. It was designed with the methodological precision of a pharmaceutical research program, because that is what it was presented as within the SS institutional structure. The wound infection was standardized across subjects, the same bacterial mixture, the same wound depth, the same suturing technique, to produce comparable efficacy data across a sample large enough to be statistically meaningful. The protocol was designed to replicate the conditions of a battlefield wound with gas gangrene contamination, because the research question the SS medical literature described was whether sulfonamide compounds could treat gas gangrene under field conditions. The answer the protocol was designed to produce was a legitimate military medical question. The method by which the answer was generated was what the Nuremberg Code was subsequently written to prohibit. The Nuremberg doctors' trial prosecuted 23 physicians. The Ravensbrück experimental program involved more than 23 physicians across its operational period. The criterion for prosecution was not the severity of participation. The documented evidence available to the prosecution team established participation by a larger group. The criterion, as it emerged from the institutional decisions made by the prosecutorial apparatus, was a combination of documentary evidence strength, institutional visibility, and the absence of post-war utility to Allied medical or intelligence programs. The physicians who were tried were tried. The physicians who were not tried returned to their practices, to their academic positions, to their journal subscriptions. Brigitte Baylor-Galanda, in research published by the Documentation Center of Austrian Resistance in 2001, documented that at least 5 physicians who had participated in the Ravensbrück experimental program resumed licensed medical practice in post-war Austria and West Germany without any formal proceedings, and that at least 2 published peer-reviewed research in the 1950s that cited prior work conducted during their wartime service without disclosure of the conditions under which that prior work had been conducted. The silence in the West German medical establishment about the wartime activities of colleagues who had returned to clinical practice was not a silence of ignorance. The colleagues knew each other. They had trained in the same institutions, attended the same conferences, read the same journals. The silence was a professional decision, made collectively and without formal coordination, to manage the past in a way that allowed the present to continue functioning. The patients of the physicians who resumed practice after Ravensbrück did not know the history of the hands examining them. The colleagues who shared conference panels with those physicians knew it and addressed it through the mechanism of not addressing it, which is a form of address that produces no record and leaves no archive. But here is where the conventional reading collapses into something stranger. Some were prosecuted, some were not. The data both groups produced went into the same journals. The journals are still in the libraries. The physician who stood in the dock at Nuremberg and the physician who sat in the gallery both contributed to a body of research that the post-war medical establishment used because it was useful, and cited because it was available, and did not always disclose, because disclosure was not required by any protocol that existed at the time. The Nuremberg Code was written partly to create such a protocol. It was written after the fact. The data it was written to prohibit generating had already been generated. The prohibition arrived after the research. The research arrived in the literature before the prohibition. The sequence matters. The physicians who stood in the dock at Nuremberg were prosecuted for what they did. The physicians who sat in the gallery went back to their practices. The data both groups produced went into the same journals. The journals are still in the libraries. Number 5. Eukodal. 80. That is the number of distinct pharmaceutical compounds that Allied pharmacological analysts identified in the injection logs kept by Theodor Morell when those logs were recovered from the Reich Chancellery in 1945. 80 compounds, in a single year of treatment. Administered by injection, not prescription, not tablet, not any delivery mechanism that involves the patient making an independent decision about timing or dosage. Some compounds daily, some multiple times daily, some in combinations that no pharmacological literature before or since has described as a recognized treatment protocol for any identified condition. The logs are precise, they are dated, they are timed, they are signed in Morell's hand with the specificity of a man who understood that what he was recording was medically significant, and who did not appear to understand, or did not appear to care, that what he was recording was medically unprecedented. The patient receiving the injections was the supreme commander of the German armed forces. The logs describe his pharmaceutical state during the most consequential military decisions of the 20th century. Theodor Morell had been Hitler's personal physician since 1936. His method was injection rather than prescription because injection produces faster onset and more reliable bioavailability than oral administration, and because Morell had built his pre-war practice on a reputation for results that conventional physicians were not producing, results he achieved through a pharmaceutical aggressiveness that his colleagues found irregular and his patients found effective. By the time the war began, he had access to the full resources of the Reich pharmaceutical industry, which meant that the compounds available to him were not limited to what a civilian physician could obtain through normal channels. The injection logs from the war years describe a regime that expanded progressively as the military situation deteriorated. In the early war years, the entries are relatively bounded. Vitamins, glucose, a proprietary compound Morel had developed called Mutaflor. By 1943, the entries had expanded to include Eukodal, a synthetic opioid developed by the German pharmaceutical company Merck in 1917, which is chemically and pharmacologically the direct precursor of modern oxycodone. By 1944, the logs record Eukodal injections with a frequency that modern addiction medicine would classify without ambiguity as opioid dependency. What daily opioid administration produces in a user over months and years is not a disputed question in the pharmacological literature. The opioid receptors in the central nervous system downregulate in response to sustained exogenous opioid supply, which means the baseline level of the endogenous opioid system decreases in proportion to the synthetic supplement being provided. The result is a state in which the patient requires the compound to reach normal baseline function, not elevated function, not pharmaceutical enhancement, but the ordinary functional baseline that existed before the dependency developed. The cognitive effects of opioid dependency at the doses Morel's logs suggest include a narrowing of attentional focus, a reduction of anxiety that in a clinical context is therapeutic, and in a command context represents the suppression of the threat assessment capacity that military decision-making requires, an impairment of complex sequential reasoning, and an emotional flattening that reduces the range of effective response available to the dependent person. Morel was also administering amphetamine compounds. The combination of opioid dependency managed with stimulant supplementation produces alternating states of sedated narrowness and artificial energy that the person inside the cycle experiences as functional. The logs from outside the cycle describe something different. The military decisions recorded in the operational history of the German armed forces between 1943 and 1945 were made by a man whose pharmaceutical state Morel's logs document with daily precision. The decision in the summer of 1943 to refuse the withdrawal from the Kursk salient that his generals were requesting, a refusal that resulted in the destruction of the armored force that Germany could not replace, the decisions of 1944 that Army Group commanders described in their own post-war accounts as disconnected from the operational reality their reports were describing. The final months in the bunker, where the decisions recorded in the military logs bear a relationship to the available forces and the actual strategic situation that the pharmacological literature on late-stage opioid dependency and stimulant cycling would predict with uncomfortable accuracy. The logs do not prove causation. They establish the pharmacological context in which the decisions were made. The context is in the record. The decisions are in the record. The two records have been sitting in adjacent archives for 80 years. The Reich, whose ideology promised a master race, physically perfect, pharmacologically abstinent, the embodiment of biological superiority, administered that ideology through a supreme commander who required Morel's needle to begin each day. The propaganda apparatus maintained the public image of iron health and austere discipline with the same efficiency it maintained every other Reich narrative. The newspapers described a man of ascetic habits. The radio broadcasts carried a voice of absolute conviction. The injection log for the same days describes a man receiving opioids, vitamins, hormones, amphetamines, and compounds whose precise nature Morel's own notation sometimes obscures, in a pharmaceutical regime that has no equivalent in any other documented case of political leadership in recorded history. The gap between the public body and the injected body was managed by a physician with a needle, a classification stamp, and the professional discretion of a man who understood that his position depended entirely on his patient's continued functioning. Norman Ohler, in his 2015 study Blitzkrieg, reconstructed Hitler's pharmaceutical regime from Morel's preserved injection logs and concluded that by 1944, the frequency and combination of compounds being administered constituted opioid dependency by any modern clinical definition, and that the withdrawal periods between Eukodal injections correspond in the logs with documented episodes of physical collapse and extreme behavioral dysregulation that contemporary witnesses recorded without understanding their pharmacological cause. But here is where the nightmare begins. The first impossibility is that the man commanding the largest military force in European history was, by the pharmacological definition available in his own physician's logs, an opioid-dependent patient whose cognitive and affective capacity during the war's most critical decision-making periods was being managed by a compound whose dependency profile Morel understood and whose cognitive consequences Morel did not document, because documenting them would have required the log to say what the log would not say. The second impossibility is worse. The regime whose foundational ideology classified entire populations by their biological fitness, whose propaganda apparatus constructed the image of its leadership as the physical expression of that fitness, was led by a man whose daily existence required pharmaceutical maintenance at a scale and complexity that no other head of state in recorded history has left in such precise documentary form. The ideology said one thing. The injection log said another. The ideology was public. The log was classified. The men who fought for the ideology did not know about the log. The log is now in archives. The ideology is in history books. Both are true simultaneously. The Reich's ideology promised a master race. Its supreme commander required 80 pharmaceutical compounds a year to remain functional. The gap between those two facts was managed by a physician with a needle and a classification stamp. It was the most consequential gap in the history of modern governance. Number 4. DIX. The pharmaceutical laboratory at Sachsenhausen concentration camp in 1944 was equipped with standard research apparatus, chemical storage cabinets arranged along the walls, a tablet press of the kind used in any industrial pharmaceutical facility, workbenches with the particular orderliness of a space where precision is professionally required. The prisoners selected to work in it had been chosen for their pharmaceutical or chemical training, because the work required people who understood what they were producing. The work in the autumn of 1944 was synthesis and formulation, 3 compounds at specific ratios: cocaine, methamphetamine, specifically Pervitin, Eukodal. The tablet that came out of the press had a designation, DIX. It was not for the prisoners in the laboratory. It was for the men who would be required to sustain physical performance at levels the human body was not designed to maintain. Establishing that DIX could sustain those levels required a different group of prisoners entirely. The selection for the performance trials was made by the same institutional apparatus that had made every other selection at Sachsenhausen. The criteria were physical condition and what the trial records described as suitability for extended load-bearing activity. The SS Pharmaceutical Research Program that produced DIX was not a rogue operation conducted outside normal institutional channels. It was authorized through the SS Medical Command Structure and connected to the broader German military pharmacological research program that had been running since the Pervitin trials of 1939. The stated military application was specific: extended performance for submarine crews facing the operational demands of late-war Atlantic conditions, where convoy escort had made submarine patrols longer, more physically demanding, and more psychologically sustained than any earlier period of the war. Special operations personnel and mission profiles that exceeded the endurance parameters of unmedicated human performance. The 3-compound formula was designed to combine cocaine's local stimulant and vasoconstrictive properties, methamphetamine's central nervous system activation and sleep drive suppression, and Eukodal's pain management and anxiety reduction into a single compound that addressed the full spectrum of performance limitations simultaneously. On paper, the pharmacological logic was coherent. The performance trial was designed to confirm it. The trial circuit at Sachsenhausen was a path around the perimeter of the camp. The prisoners selected for the DIX performance assessment were required to walk it carrying packs, weighted to replicate the load-bearing requirements of a submarine crew member moving equipment through a vessel under operational conditions. The distance was significant. The weight was significant. The records describe the distances achieved under DIX supplementation in the language of pharmaceutical research: efficacy metrics, performance differentials relative to unmedicated control conditions, tolerance profiles across repeated administration. The prisoners who collapsed before the trial designers had gathered sufficient data appear in the records as incomplete trials. The prisoners who completed the distances appear as successful trials. What the successful trial felt like from inside the person completing it, carrying weight around a concentration camp perimeter under a combination of cocaine, methamphetamine, and opioids, while being observed by the SS physicians recording their performance data, is not in the trial records. It is in the testimony of the prisoners who survived and spoke after the war, which is a different document. The DIX research files were among the records that the retreating SS attempted to destroy as Allied forces closed on Sachsenhausen in the spring of 1945. The destruction was incomplete. What Allied forces recovered was sufficient to establish the program's existence, its authorization, its methodology, and its results. What was not recovered, or what was recovered and has not been fully accounted for in the public record, is the question of whether the DIX formula or its specific compound ratios entered post-war pharmaceutical or military research through channels that did not disclose their origin. The three compounds in DIX are not exotic. They are the three classes of performance-modifying compounds that military and civilian pharmacological research has continued to evaluate in various combinations and delivery systems since 1945. The specific combination was never replicated in any sanctioned program under that designation. The question of whether the Sachsenhausen trial data influenced any subsequent research program is not fully answered by the surviving records, because the subsequent research did not always cite its sources with the specificity that would make the answer visible. The submarine application for which DIX was developed had a specific geographic theater. The late war North Atlantic, the convoy routes from North America to Britain that American and Canadian escort groups had progressively dominated through the Middle War years, forcing German submarine operations into longer, deeper, more sustained patrols with lower success rates and higher loss rates than any earlier period of the war. The DIX program was designed to address a specific operational problem, which was that the human beings required to conduct those patrols were reaching the limits of what unmedicated human endurance could sustain. The pharmacological solution to that problem was being tested on prisoners at Sachsenhausen, while the submarines it was intended to supply were being sunk in the Atlantic faster than they could be replaced. The program never reached deployment. The war ended first. Wolf Kemper, in research documented in the journal Suchtmedizin in 2006, confirmed from recovered Sachsenhausen trial records that DIX test subjects achieved sustained physical performance metrics at levels that exceeded unmedicated human baseline by margins consistent with the three compound formula's pharmacological profile, and that the trial protocol made no provision for the post-trial welfare of subjects who survived the performance assessment, because the institutional framework within which the trial was conducted had no category for the welfare of subjects whose participation had not been voluntary. But here is where the standard explanation falls apart. The formula worked. That is the first thing the record establishes. Prisoners marched distances under DIX that the pharmacological profile of the compound predicts they could not have marched without it. The achievement is documented. The second thing the record establishes is that the achievement and the atrocity are not separate events with separate documentation. They are the same event described from two positions. The performance data and the forced march are in the same file. The file does not separate them because they cannot be separated. DIX was never deployed. What was not deployed was the compound. What was not ended was the question the compound was built to answer. That question has had funding, in various forms, in various militaries, in every decade since. Number 3. Kampfstoff-D. In the spring of 1945, a British Army chemical warfare specialist named Major Edmund Tilly entered a storage facility near the town of Lossa, in central Germany, and filed a report unlike any he had previously written in any theater of operation. The report was classified at the highest available level before it left his hands. What Tilly had found in the storage facility itself was the nerve agent stockpile, a quantity of tabun and sarin that exceeded every Allied intelligence estimate of what the Reich possessed. But what had accompanied the stockpile in filing cabinets that the retreating SS had not destroyed was something the briefings had not prepared him for. Not just the weapons, the antidote research, the clinical trial records that documented how the antidotes had been tested, on which subjects, at which exposure levels, with which outcomes. Tilly quarantined the facility and classified the weapons under standard chemical warfare protocols. The research files traveled separately, under different orders, to a different destination. Where they went is in the declassified record. What was done with them is also in the declassified record. The declassified record is in the archive. The archive is open. Most people who use nerve agent antidotes today have never been told any of this. Nerve agents disrupt the acetylcholinesterase enzyme, which is the compound the nervous system uses to terminate the signal between nerve and muscle after each contraction. When acetylcholinesterase is inhibited by a nerve agent, the signal does not terminate. The muscle keeps contracting, every muscle, simultaneously. The progression begins with the small muscles, the pupils constricting to pinpoints, the salivary glands producing saliva the body cannot manage, the tear ducts overflowing. It moves to the larger muscles. The bronchial passages constrict. The diaphragm seizes. At sufficient exposure concentration, the respiratory muscles stop. The body suffocates from inside, every muscle working at maximum, the lungs included. In a spasm, the conscious mind is present for, until the oxygen runs out. The German researchers at Neuengamme and Natzweiler concentration camps were attempting to establish, through human trials, the specific atropine dosages that could interrupt this progression at each stage, and the timing windows within which antidote administration could be effective at different exposure concentrations. Those are legitimate pharmacological questions with genuine life-saving applications. The method of establishing the answers was the administration of nerve agents to prisoners at sublethal and near-lethal exposure concentrations, and the observation of outcomes. The decision not to deploy Germany's nerve agent stockpile is one of the most consequential non-events of the Second World War. The Reich possessed tabun and sarin in quantities sufficient to have altered the course of specific campaigns. The strategic calculus against deployment was specific. German military planners assessed that the Allies possessed equivalent chemical warfare capability and would respond in kind, a retaliatory capacity that would fall on German cities and German forces with effects the Reich's defensive infrastructure could not manage. The assessment was wrong. The Allies did not possess nerve agents in equivalent quantities. But the German assessment of Allied capability was based on the assumption that the Allies, having been fighting the same war, had arrived at the same pharmacological discoveries through independent research. The assumption was incorrect. The antidote research that accompanied the stockpile was therefore research conducted on prisoners to prepare for a deployment that a mistaken strategic assessment would prevent, and then classified and transferred to Allied authorities who used it to develop antidote protocols for the nerve agents they subsequently acquired through the same German research. The atropine autoinjector carried by military personnel in every NATO country today delivers a specific dose of atropine at a specific speed into the bloodstream of a person exposed to nerve agents. The dose was not established by laboratory chemistry alone. The therapeutic window, the quantity of atropine that interrupts nerve agent toxicity without itself producing atropine toxicity, the timing parameters within which the antidote is effective at different exposure concentrations. These clinical parameters required human data at exposure levels that no ethics board would have permitted to generate through voluntary human trials. The concentration camp antidote research provided that data. American chemical warfare authorities received the files in 1945. The files were incorporated into American military chemical defense protocol development under classification. The classification has been partially lifted. The incorporation is in the declassified record. The auto-injector is in the field. The nerve agent antidote research files were classified by Allied authorities for reasons that the declassified communications make explicit. The data was pharmacologically valuable. Its origin was criminally compromising. The institutional decision to treat the data as intelligence rather than exclusively as evidence was made by named officials in the Allied chemical warfare apparatus who understood both categories and chose the proportion between them. Jonathan Tucker, in his 2006 study War of Nerves, documented that American chemical warfare authorities received and processed the German nerve agent antidote research files in 1945, and that the clinical data was incorporated into American military chemical defense protocols, a fact not publicly acknowledged until the relevant records were partially declassified in the 1990s. But here is where the conventional reading collapses into something stranger. The antidote works. That is the first fact. The prisoner in the Natzweiler nerve agent trial did not consent to establishing the therapeutic dose. That is the second fact. The soldier who survives a nerve agent attack today because the auto-injector delivers the correct dose at the correct speed does not know how the correct dose was established. That is the third fact. All three facts are in the archival record. The distance between them is not ignorance. It is classification and the passage of time and the institutional preference for using knowledge without examining where it came from. The antidote is in service. Its origin is in the files. The files are partially open. The chain from the Natzweiler trial room to the auto-injector in the field kit is unbroken. It has simply been made invisible by the distance between 1945 and now. The antidote works. It was tested on people who were given no choice about being tested on. The testing produced the dose. The dose is in the injector. The injector is in the kit. The kit is in the field. The chain is unbroken. It has simply been made invisible by the distance between 1945 and now. Number 2. Mescaline. 30. That is the number of Dachau prisoners documented in the SS experimental records as having been administered mescaline under interrogation conditions between 1942 and 1944. 30 subjects. Documented outcomes. Classified at the highest SS medical classification level before the files left the facility. When American intelligence officers entered Dachau in April 1945 and began processing the experimental records, the mescaline files were separated from the other medical documentation and routed to a different processing stream. They did not go to the evidence teams preparing the Nuremberg case. They went to a different office, with a different mandate, whose interest in the Dachau pharmacological research was not prosecutorial. The separation happened in April 1945. The Nuremberg doctors' trial began in December 1946. The files that had been separated in April 1945 were not returned to the evidence stream in the intervening 19 months. They were being used for something else. The SS framing of mescaline as a potential truth serum was not arbitrary. The compound, derived from the peyote cactus and known to Western pharmacology since the 1890s, produces altered states of consciousness characterized by a specific profile: perceptual distortion, heightened emotional responsiveness, a reduction in the capacity for deliberate narrative construction that some researchers had theorized might reduce a subject's ability to maintain a prepared false account under questioning. The theoretical basis was thin by any rigorous standard. The SS medical literature described it as promising. The program was authorized through the Dachau experimental apparatus that was simultaneously running high-altitude physiology trials, hypothermia research, and malaria compound testing in adjacent wards of the same facility. The mescaline interrogation research was one program among several, connected to the others by shared institutional infrastructure, shared prisoner population, and shared classification level. What distinguished it was where the files went after April 1945. The Central Intelligence Agency's MKUltra program was authorized in April 1953. Its stated purpose was the development of interrogation enhancement techniques using pharmacological and psychological methods. The internal CIA documents that authorized MKUltra reference prior research explicitly. Among the prior research referenced is the Dachau mescaline interrogation program. John Marks, in his 1979 study The Search for the Manchurian Candidate, documented using declassified CIA files that the agency explicitly cited the Dachau mescaline research as a foundational reference in the design of MKUltra, and that at least 3 of the interrogation protocols developed under MKUltra directly replicated experimental parameters established at Dachau. MKUltra ran until 1973. It administered psychoactive compounds, including LSD and mescaline, to unwitting subjects in the United States and abroad. It killed people. Its director, when congressional investigation closed in, ordered the destruction of the program files in 1973. What survived the destruction, because copies had been misfiled in financial records and were not included in the destruction order, is what Marks and subsequent investigators worked from. The program ran for 20 years in the direct methodological tradition of what had been done at Dachau, under American institutional authority, with American subjects, funded by American taxpayers who did not know it existed. What the Dachau prisoners described about the mescaline experiments is in the survivor testimony assembled by post-war investigators and in the records of the International Tracing Service. Forced mescaline administration under interrogation conditions, administered to people who had no framework for what was happening to them and no category in which to place the experience, produced states that the SS research notes describe in clinical outcome language and that the survivor accounts describe in phenomenological language. The two descriptions are not of the same experience. The clinical notes describe what the physicians observed. The survivor accounts describe what it was like to be the person the physicians were observing in a concentration camp, having been administered a consciousness-altering compound by people with institutional authority over every aspect of the subject's existence. The gap between those two descriptions is not a gap in the data. It is a gap between two different relationships to the same event, one of which was classified and used, the other of which was testimony and largely set aside. The SS physicians who designed and administered the mescaline research at Dachau held academic credentials from German universities. They had trained in the same pharmacological tradition that had produced the legitimate medical research of their era. Some were prosecuted at Nuremberg. Some were not. The ones who were not returned to various forms of professional life in the post-war period. The ones who were prosecuted were tried under the Nuremberg Code, a document written in 1947 specifically to prohibit administering compounds to unwitting human subjects without consent. The CIA's McUltra program, which began in 1953, 6 years after the Nuremberg Code was written, administered compounds to unwitting human subjects without consent for 20 years. Both the code and the program were products of the same government. They occupied different institutional compartments. One compartment was published in the official record of the Nuremberg trials. The other was classified until a Senate committee forced its partial disclosure in 1977. But here is where the nightmare begins. The program that prosecuted the Dachau physicians at Nuremberg was running a classified continuation of their research simultaneously. Not metaphorically, methodologically. The same compounds, the same unwitting administration, the same interrogation context, the same absence of consent. The institutional body that established in open court that doing this constituted a crime against humanity was doing it, in classified programs, under its own authority, in the same decade. The Nuremberg Code and McUltra are both in the archives. The reading room is open. The Nuremberg Code prohibited what Dachau did. McUltra continued it. Both are products of the same government, in the same decade, filed in the same archives. The prohibition and the continuation are equally documented. The documentation is the disturbing part. It means no one forgot. It means someone decided. Number 1. Unit 731. The complex at Pingfan, 12 kilometers south of Harbin in Manchuria, looked from the air like a standard military installation. Barracks arranged in orderly rows. Administrative buildings with the institutional geometry of a facility built with adequate resources and deliberate planning. Research laboratories. A perimeter wall. The kind of organized spatial logic that a military research installation produces when it has been given both time and money. In 1936, when construction began, the official designation was the Epidemic Prevention and Water Purification Department of the Kwantung Army. The name was chosen with care. Epidemic prevention and water purification were among the subjects studied at Pingfan. The name was accurate in that narrow sense. In every other sense, it was the most precisely constructed institutional lie of the 20th century. What was studied at Pingfan between 1936 and 1945 was not the prevention of disease. It was the engineering of disease as a weapon, tested on the bodies of prisoners who were transported to the facility, experimented on until they died or were killed, and then incinerated in a crematorium designed for the purpose. The prisoners were Chinese, Korean, Soviet, and in some documented cases, Allied prisoners of war. They were not registered by name in the facility's internal records. They were registered by number. The institutional term for a human being inside the Unit 731 research program was Maruta. It means logs. It means something to be consumed in the production of something else. Shiro Ishii had been arguing since the 1920s that biological warfare represented the future of military capability and that Japan was behind the major powers in developing it. His institutional position within the Imperial Japanese Army gave him access to the decision-makers who could authorize what he was proposing, and in 1931 he received the first authorization to develop a biological warfare research program. What grew from that authorization over the following decade was the largest state-sponsored human experimentation program in the history of warfare, staffed by over 3,000 researchers at its peak, operating across multiple facilities in Manchuria and China, and producing a body of data on the lethality, transmission, and weaponization of biological agents that no program operating under any ethical constraint could have generated. The Plague Program, the Cholera Program, the Typhoid Program, the Anthrax Program, the Frostbite Experiments, conducted by exposing prisoners to sub-zero temperatures to establish the threshold of irreversible tissue damage, the Pressure Experiments, the Vivisection Protocols, in which prisoners were dissected alive to examine the progression of infection in living tissue because Ishii had determined that fixative compounds used in standard autopsy preparation altered the data in ways that living tissue examination would not. The research was thorough. The methodology was consistent. The outcomes were documented. The documentation was, by the standards of the data it contained, extraordinarily complete. The immunity transaction is in the documents. It is not alleged. It is not inferred. It is in the communications between American intelligence officers and the War Department, in the internal memoranda that weigh the options, in the explicit language of the decision that was made. What American intelligence offered Ishii and his senior researchers was immunity from prosecution at the Tokyo War Crimes Tribunal, which was running simultaneously with the Nuremberg trials and which was examining Japanese war crimes under the same institutional framework. What Ishii offered in exchange was the Unit 731 data, the complete research findings, the lethality calculations, the transmission parameters, the weaponization methodologies, the epidemiological data generated by releasing plague-infected fleas over Chinese cities in ceramic bomb casings. The decision that was made by named American officials in documented meetings was that the data was more valuable to American biological warfare research capability than the prosecution of the men who had generated it. The Nuremberg Code was written the following year. The immunity held. Sheldon Harris, in his 1994 study Factories of Death, documented using declassified American intelligence files that the decision to grant immunity was made at the level of General Douglas MacArthur's headquarters and involved the explicit suppression of evidence that would have been material to the Tokyo Tribunal, which the same institutional authority was simultaneously administering. What Ishii ordered destroyed before Soviet forces reached Pingfan was thorough and rapid. The prisoners still alive in the facility were killed. The main research buildings were demolished. Documents were burned. The crematorium worked continuously in the final days. What survived was what the speed of the Soviet advance did not allow the destruction to reach. The Soviet forces who entered Pingfan found a facility in the process of erasure and recovered enough from the incomplete process to conduct their own investigation. The Soviet War Crimes Tribunal at Khabarovsk in December 1949 tried 12 members of Unit 731 using testimony and surviving documentation. The proceedings documented the program's scope, its methodology, and its human cost with a specificity that the surviving records supported. Western governments dismissed the Khabarovsk proceedings as communist propaganda at the time. The declassified American documents explain why. Acknowledging the Khabarovsk findings would have required acknowledging that the Tokyo Tribunal had omitted the prosecution of men whose crimes the Khabarovsk evidence documented, and that the omission had been deliberate, and that the reason for the deliberateness was the immunity transaction that was not supposed to be in the public record. The American Biological Warfare Program at Fort Detrick, operational from 1943 to 1969, when President Nixon terminated it by executive order, developed along research lines that the Unit 731 data had established. The Soviet Biopreparat program, which the Soviet government did not officially acknowledge until its director defected in 1992, and which continued operating until at least the early 1990s, incorporated Unit 731 findings through both the Khabarovsk records and independent Soviet intelligence collection at the Pingfan site. The programs are in the archives. The lineage is traceable for anyone willing to follow the citation chain from the post-war bioweapons development literature back through the intelligence acquisition records to the Pingfan research files. The chain is not hidden. It is simply long enough and technical enough and distributed across enough separate institutional archives that following it requires a sustained effort that most people with access to it have not made. But here is where the conventional reading collapses into something stranger. The post-war justice system did not fail to address Unit 731. It chose not to. The evidence existed. The witnesses existed. The documents existed. The decision not to prosecute was made by named officials in documented meetings with explicit reference to the intelligence value of what was being exchanged for immunity. This was not a failure of information or a failure of institutional capacity. It was a transaction. The institution that was simultaneously establishing at Nuremberg that crimes against humanity cannot be excused by any strategic necessity made a classified decision that the crimes of Unit 731 could be excused by strategic necessity, because the necessity was real and the classification would hold, and the two decisions would not need to be reconciled because they would occupy different compartments of the same institutional body. One compartment was open to the public, the other was classified for decades. Both are now in the archive. The archive is open. The reconciliation has not occurred in any official document. It has been left, like most things that are too expensive to reconcile, to history. The prisoners at Pingfan were called logs. The data produced by the logs was purchased by an institution that had simultaneously established in open court that producing that data was a crime against humanity. The purchase price was immunity. The immunity held. Ishii died in Tokyo in 1959, in his own bed, never prosecuted, throat cancer taking the time that justice declined to take. The data he sold is in the programs that were built with it. The programs are in the archives. The immunity is in the record. The logs had names. The names were not part of the transaction. They were what made the transaction possible. That distinction between the data that was purchased and the people whose deaths produced it is the precise moral location of everything the post-war world built and then chose not to examine. The war ended. The data did not. The immunity held. The logs had names. The names were not part of the transaction. They were what made the transaction possible. That distinction is still open. It has not been closed by any institution with the authority to close it. It will not close on its own. If you want to see more videos like this, click the video on screen now and make sure to subscribe.